right. Welcome everyone to Grand Rounds. We'll give folks a minute or so to come in from the waiting room. We have a wonderful speaker today. Really excited about Dr. Gulati, and I'll turn it over to Dr. Salas.
Good morning. It's so wonderful to be here with everybody, continuing our celebration of Women in Medicine Month. Roussel, do you mind to put up the slides? We just have a couple of slides, and I'm going to go through them really quickly because I want to give Dr. Gulati time, and I want us to all benefit from hearing from her. So real quick, it is Women in Medicine Month. We've had two excellent pieces in our newsletters already. These are in our regular departmental newsletters that go out, and if you've missed them, please check them out. The first one was from Jocelyn Hollings on the intersection of life and work, a really powerful piece, as is Dr. Diana Farid's piece that just came out yesterday, To Heed the Whisper, both really inspiring and moving pieces. So keep an eye out. We'll have those continuing through the month, and we're doing spotlights on social media. Next slide, please. Importantly, today is our Women in Medicine Photo Day. So at noon at the Clark Center steps, we're doing the in-person photo. And then for those who are not able to make it, we're also doing the virtual photo from 4 to 4:30. So I hope that as many people as possible can join us. And these are, you can see in the background pictures from previous years. Next slide, please. I will put the link for this in the chat. This is a survey that's a GME-wide survey for residents and fellows. Next slide. And just two events that we have coming up, just to keep in mind, we have an event celebrating National Disability Employment Awareness Month that's coming up October 3rd. And so you'll hear more about that in future dates. Next slide, please. And on October 11th, we have two really excellent back-to-back events, an event with the Ballet Folklorico group, as well as an LGBTQ+ health event. So with that, I'm going to get right on to, oh, sorry, one more slide, I think, on upcoming speakers. Yes, upcoming speakers. We've got Dr. Monica Vela next week, and then Dr. Elena Rios on the 28th. As many of you know, tomorrow starts National Hispanic Heritage Month. And now I think really we are on to finally Dr. Gulati. I'm so excited that Dr. Gulati is here with us today. Dr. Martha Gulati is the president of the American Society for Preventive Cardiology. She was a professor of medicine and the inaugural chief of cardiology at the University of Arizona. She's the author of the bestseller Saving Women's Hearts. She served as the National Chest Pain as the chair of the National Chest Pain Guidelines that were released last year. And she has recently joined Cedars-Sinai Heart Institute as a professor of cardiology and the director of prevention, the associate director of the Barbra Streisand Women's Heart Center, and holds the Anita, Dann, Friedman Endowed Chair in Women's Cardiovascular Medicine and Research. I just need to tell you a little bit more about her because she's amazing. Her commitment to the study of women and cardiac diseases has won her numerous awards and distinctions, including Crane's Chicago Business as one of Chicago's top 40 under 40, and the first Credo Coalition to Reduce Racial and Ethnic Disparities in Cardiovascular Outcomes Award from the American College of Cardiology, as well as the National Red Dress Award for her efforts in raising awareness of heart disease in women and advancing research in this field. In 2019, she was chosen as the most influential woman in Arizona and received the American College of Cardiology's Bernadine Healy Award for her leadership and accomplishment. She currently is the principal investigator of the St. James Women Take Heart Project, a study examining cardiac risk factors in women, which sets standards for women's fitness levels and heart rate response for exercise in women. She's also a co-investigator on the Women Ischemic Syndrome Evaluation Study and previously served as a co-investigator on the Women's Health Initiative. She's published many articles in all the big journals, New England Journal, Circulation, JAMA, etc. And most importantly, well, I don't know about most importantly, but wait for it, she has been featured on Oprah. So I am so excited to have Dr. Gulati here, and we are fortunate to have her sharing her insights. Without further ado, Dr. Gulati, I turn it over to you. Thank you so much for being here.
Well, thank you for having me, and thank you for the kind invitation, Dr. Salas and Dr. Harrington and Dr. Harmon, really kind. And so I'm going to just get up my slides here. So I'm going to talk today about the second sex. I'm going to be talking a little bit about medicine, but also about cardiology in general, our field of cardiology. So let's get started. I have no disclosures. And I think that for those of you who have read The Second Sex or know the book, I mean, it's something that was pivotal to my growing up, and Simone de Beauvoir, you know, this quote, her wings are cut and then she is blamed for not knowing how to fly. And I think for so many topics that you'll have during this Women's Month about in medicine, you know, these are issues that we deal with all the time. So today I'm going to talk about some of the inequities in cardiovascular care of our female patients, but also to help us understand the inequities within the cardiology community. And many of the lessons that we're learning in cardiology obviously apply to medicine in general, but I can only give you my perspective as a cardiologist. And then I'm going to hopefully outline some solutions that can improve the health of everyone. Cardiovascular disease, as you know, is the leading killer of both men and women. And more than 2 decades ago, we were talking about why are more women dying? And, you know, men were actually, there was a decline in cardiovascular disease. And as we talked, it wasn't that we necessarily enrolled women into trials. We just saw the data going up. It wasn't until about the year 2000 that we started really having a Go Red campaign, specific guidelines for women. We had studies that enrolled women and we improved because you can see this dramatic reduction in mortality, but we still aren't anywhere near understanding everything about women's cardiovascular health. And in fact, what's been happening in the last decade is very disturbing for both men and women while we're watching the mortality increase for both from cardiovascular disease. Now, specifically for women, we've talked about the bikini approach to women's health. And if you don't know this term was coined by Dr. Nanette Wanger, who is my mentor and idol, and really the mother of cardiovascular disease in women. And she talked about the medical community viewing women's health really with a bikini approach, essentially looking at the breasts and the reproductive system and ignoring the rest of the woman when we talk about women's health. She said that many years ago. In fact, I take this quote from when I was in medical school and got to meet her for the first time. And then I've subsequently written more recent editorials. When are we going to move beyond the bikini? How are we not going to start protecting a woman's heart? Because there is still so many barriers that we see on a daily basis. And I'm going to try to outline some of those. So we know once women have cardiovascular disease, they're more likely to die. And the first question I would ask is, do we even follow our guidelines equally in men and women? And sadly, the answer is no. I'm going to use cardiovascular disease, particularly acute myocardial infarction, where we have really good guidelines to look at what we're doing and good databases to look at what we're doing. But after an acute myocardial infarction, we know still that women are less likely to get referred to the cath lab, and they have longer door to balloon times. And we know longer times mean, you know, worse outcomes. Women are less likely to get thrombolytics in places that don't have cath labs, and they also have longer door to needle times, meaning time from entry to injection. We know guideline-directed medical therapy is less likely to be given to a woman compared to a man after a myocardial infarction. And it doesn't matter if you're looking at acutely, like within the first 24 hours, or even upon discharge. We also know that women are more likely to be readmitted over time, and we can look from the 90s to now, and there is some improvement, but the trends persist. So since we started looking at this, we still haven't closed the gaps. And as a result, we see increased mortality in women, particularly in the ST elevation myocardial infarction group, but also in young women who present with acute myocardial infarction. That's the group that does the least well. And we have looked, we just recently published a paper that I've given you the reference down below. We looked at globally to see, you know, what is it just in the United States? But no, every country that has reported their results by sex has shown that this is a global problem. There is no one country that's like better at it than others, that somehow there is a bias in how we care for women compared to men. One of the problems is that a lot of heart disease, particularly myocardial infarction or ischemia, women present with chest pain for evaluation. And we know specifically we're concerned about young women because they have the highest mortality. So this study that was published this year from the National Hospital Ambulatory Medical Care Survey, representing 4 years and 29 million emergency room visits, looking at young adults between the ages of 18 and 55, found that women and also people of color waited longer to be seen by physicians. They were less likely, women, to be triaged as an emergent case. It took about 10 minutes longer for them to get evaluated compared with men. They were less likely to get an EKG or less likely to get any type of cardiac monitoring, less likely to be seen by a cardiologist, less likely to be admitted. So it's no surprise that young women do less well, because even when they present with the symptoms that we say should be addressed, go to the emergency room, call 911, we still don't treat them in the same degree of urgency as we do with men. And even after we diagnose cardiovascular disease, even when we know that they have it, we know from a recent paper, again, I tried to give you more recent literature, that women compared with men are less likely to receive statin therapies. So they have known cardiovascular disease. This is a simple measure of just knowing, are they getting guideline-directed care? And being a woman means that you're less likely to get these life-saving therapies. Another study that was published in 2009 looked at acute myocardial infarction in young women and young men, and showed also in the hospitalization, women are less likely to get lipid-lowering therapy, less likely to get beta blockers, less likely to get antiplatelet agents, less likely to get revascularized or referred even for invasive angiography. So the youngest people with the most to lose are the ones that we treat the least aggressive. Now, also the sickest patients are less likely to receive aggressive care. And this is a study that was published looking at people with an ST elevation myocardial infarction who are in cardiogenic shock. And this is using a national inpatient sample. And they found that women, the sickest women, were less likely to receive invasive therapy, whether that's revascularization or mechanical circulatory support. It was less likely to occur in women and also less likely to occur in people of color. And as a result, the highest mortality again was in women and again in Black and Hispanic people. Now, when we talk about utilization, the other types of diseases, because I focus heavily on ischemic heart disease because it's the most common thing we see in our clinics. But I want to point out that even utilization of novel or sort of newer therapies in other diseases, other cardiovascular diseases, are less likely when you're a woman compared to a man. TAVR. This is a procedure that isn't even new anymore, but we know women do better than men. They have better outcomes compared with men when they receive this therapy. Nonetheless, we don't utilize it. Now that the trials are done, we don't utilize it as easily in women. We don't offer it to our female patients in the way that we do for men. Atrial fibrillation, we know women are less likely to receive adequate anticoagulation. They're less likely to get other anticoagulants other than Coumadin. We don't use our therapies well. We also don't offer them rhythm control or ablation the same way that we do men. ICDs and CRT specifically, women do better compared with men, the cardiac resynchronization therapy. And yet we don't, again, we have a lot of data in the United States showing that men compared to women are more likely to get CRT with or without pacemakers than women. And yet women are the ones that derive the greatest benefit. And heart transplant, to only 25% of our heart transplants go to women. And LVAD therapy, the prelude to transplant often, and sometimes can avoid transplant, again, is only utilized in about 25% of women. So The other question you might ask, you might be saying, well, there's these delays, maybe women are different than men, maybe they experience cardiovascular disease differently. Well, I hope to dispel that myth as well. And using, again, ischemic heart disease or presentations where we know people have ischemic heart disease or myocardial infarction, we have shown that actually women don't present that much differently than men. There are some differences, though, and I'll try to highlight them. So the Virgo study was a study looking at young men and young women. And these, by young, that definition is under the age of 55. And what they found is that 90% of women and 90% of men reported chest pain. So the difference, though, between men and women is that women had 3 or more accompanying symptoms. So chest pain might not be the most important thing that they experience, but they do report chest pain. So we need to hear them, and we need to recognize that women will report their symptoms differently. And in the Virgo study, it was interesting that quite a few of those women actually presented for care before their actual myocardial infarction. And they were told by their physicians that it was more likely that their symptoms were not cardiac, in contrast with men. So again, the whole Virgo study group is a group that has documented myocardial infarction. But we have other groups that weren't age specific, like the high stakes group. They also were able to assess symptoms. And for those who went on to have a myocardial infarction, they showed that actually women shown in red and men shown in blue in this bullseye diagram, that women were more likely to have what we consider the classic symptoms or typical symptoms. Although those of you who have read the chest pain guidelines know that I don't want you to ever use the word typical or atypical anymore. But at that time, it was okay. Similarly, the Hermes study, which was a study of artificial intelligence looking at symptoms. And basically what they did is listened into conversations. They used cardiolinguistic technology to record what the patient said. And actually, they also showed 90% of men and 90% of women reported chest pain or chest discomfort. So again, when you take out the bias in our own selves by using artificial intelligence, we see that really women are reporting the same symptoms. So we need to just understand the nuances, understand the differences, but also not dismiss women when they experience typical symptoms, when they experience chest pain. Now, one of the big problems in our cardiology community is the lack of inclusion of women in our cardiovascular trials. And I love this cartoon, and I know many of you have probably seen it, but it applies to cardiology so well. We have studies of fruit flies, mice, hamsters, frogs, monkey, and men with this condition, but medical research using women as subjects just never occurred to anyone. And for such a long time, we've been saying that in cardiovascular disease. And this study that was published 2 years ago looked at the inclusion of women in cardiovascular trials from 2010 to 2017. They looked at studies globally, and it didn't matter really the disease state. I mean, pulmonary hypertension was the exception that over-enrolled women, but all other forms of cardiovascular disease, we under-enroll women. It didn't matter if it was a study of drugs, devices, lifestyle, procedures, we under-enroll women. Doesn't matter where the study's done, doesn't matter the size of the study, really doesn't matter the age. Although under the age of 55, we are enrolling more women, but again, cardiovascular disease traditionally affects women at older ages. So we really need improved representation of women at older ages. And it didn't matter the sponsor type, although interestingly, if government funding was involved in the study, it was less likely to be women for those studies to include women. And I'm not talking just NIH. Again, this was a global study, but where government funding was involved, no one's held accountable to representing our population. Why does it matter? Well, sex matters and gender matters. Sex is biologic, and we need to understand the biological differences between men and women. Every cell has a sex, and therefore every gene and every molecule is influenced by sex. If we don't include biologic women in our studies, we're not going to understand the differences in drugs, the responses to therapies. Similarly, though, gender influences matter. Even if gender is a social construct, it influences how we approach patients, how we treat patients. And all of that needs to be included in our research. And It was back when I was in medical school, so please don't do the math, but this was the only thing I understood in the New England Journal of Medicine at that time, was this editorial by Dr. Bernadine Healy, who became my hero in that moment. She was the first woman to lead the National Institute of Health, and she talked about the Yentl syndrome, using the story of Yentl. When Yentl, if for those of you that don't know the story, if you didn't watch the movie with Barbra Streisand or read the book, Yentl disguised herself as a man to be taken seriously. And she used that analogy that the only way women will be taken seriously is if they present exactly like a man, and why we had excluded women from trials had a long history. But she said that the NIH had a commitment to improve women's health, and that she hoped that these changes she was making to include women in trials would change how we care for women. That she said that the Yentl herself would survive, but her syndrome will slip back into history as a curiosity of times gone by. But sadly, Dr. Healy would be sad to know that we're still not completely removed from Yentl syndrome. I'm just going to show you quickly a timeline, just so you understand where how slowly we've moved, I guess. In the 1960s, thalidomide was of great concern because in Europe, we were seeing the effects of thalidomide on the fetus. And so almost immediately in the 70s, the FDA excluded women of childbearing potentials in trials. Then the FDA in the 1980s said that there was a requirement for subgroups, but it actually excluded race and sex in the 1980s. Now, the NIH came out and said, we recommend women be included in studies, but there was no formal requirement. And in the 90s, when Dr. Healy was there, she established the Office of Women's Health Research, which was great. The FDA then also removed restriction for participation of women of childbearing age, and the Congress also created mandates for inclusion of women in trials. But again, none of these things actually held anyone really accountable. Now, in the 2000s, the FDA did start a pregnancy exposure registry, and in 2010, in that era, that decade, they made expectations that women would be included in medical device evaluations. Again, numbers were not stated, but it was encouraged. Now, in 2022, the FDA actually now has a framework to include sex and gender in device reporting, because that has really been lacking. And also the Academy of Medicine put out this in May of this year about reasons that we need to include representation of women and also people of diverse backgrounds in clinical trials and research. But again, despite all of this, there is nothing yet making people be accountable. And it's interesting when you look at even, human trials is one thing, but animal studies and cell studies, it wasn't until 2014 that there was this discussion between Dr. Clayton and Dr. Collins, and they unveiled a policy that, preclinical studies needed to include both male and female cell lines, male and female animals, because that's how we start the research usually, is understanding that part. And it was, I don't know if maybe the female mice bit researchers or what was going on, but they were really underused and definitely underreported. Now, as I said, no one's held accountable. And I just wanted to quickly show you, this is from the FDA, and I'm sorry I couldn't find a better picture of it. But cardiology is this light yellow line, actually, the one with the lowest enrollment of women is what they were trying to show over time. We've had some better years, but more recently, actually, we've had worse years. So that shows you that we're not held accountable. Good on you, GI, because you guys are getting women into trials, but we are really not, and we need to do better. I'll just show you an example of why using ischemic heart disease. We know that women are less likely to have obstructed coronary arteries, and they're more likely to have microvascular disease or different forms of ischemic presentations like SCAD or ANOCA or MANOCA. And we talk about the female pattern versus the male pattern. And I've shown you, I didn't show you today about difference in risk factors, but I talked about differences in presentations, differences in access and care, and therefore there's differences in outcomes. So if we don't study 52% of the population, we're not going to understand these differences. And it's taken us a long time to even understand this. And even to this day for Anoka and Minoka, we're still working on what is the best treatment. Are these terms the right terms? And there's a lot of discussion. And I'm glad that there's a lot of discussion now, but we're at the infancy of understanding women's hearts. Now, let me just change gears for a little bit. Let me talk about also, and I try to tie it all back into one package near the end. But in cardiology, we have also had a lack of women in our field. And I know there's different pockets of medicine that can also say this, but I can only talk based on my expertise within my field. Why do we need women in cardiology, and how's that going to affect even healthcare of our patients? And I am Canadian, so it's almost sacrilege for me to show something bad about William Osler, but I'm going to show you something bad about William Osler. He is Canadian, that's why it's sacrilege. So this is from his speech at Harvard Medical Association in 1894, admittedly. He said, "I come here today to tell you that co-education has proved to be an absolute failure. From our standpoint, when I tell you that 33% of the ladies, students admitted to Johns Hopkins Hospital at the end of our short session are to be married, then I tell you co-education is a failure." Well, I'm sorry, Sir Osler, this is where you and I disagree. And I show you a few things in jest. I mean, this is a funny thing from Watson and Crick made up, a sort of comedy from the New Yorker. And they wrote to Rosalind Franklin, "Dear Rosalind, thanks so much for your hard work on unlocking the secret to the helical structure of DNA. Great stuff, has been very useful for us. Sorry to leave your name off the paper. We totally forgot. We're such scatterbrains. By the way, could you fill out the online catering form for our Nobel Prize celebration luncheon? Awesome sauce. We may be Nobel Prize winners, but we're just so bad with technology." So we know that women in medicine, there's a history that we have had to overcome. And I know that it's getting better. So I don't want to be negative. I think we are improving things, but we have to recognize where we came from and where we need to go. We certainly have more women entering medicine and more women entering cardiology. We know there's more women as deans, chairs, and leadership. And your hospital, Stanford, has been such a shining example of things that can really be done with the right leadership. In cardiology, we've struggled. Since I started, we knew that there was 13% of women in cardiology. And guess what? Now there's 14%. And there's been many years between when I started and now. We have seen increasing numbers in fellows in training. So that's good news. We have lots of hashtags to create our community and help us discuss things where we need changes. And some of these are applicable just to cardiology, but many of them are applicable to women in medicine and beyond. But in cardiology, the obstacles we face, and many women in medicine face as well, there's that lack of diversity, there's gender bias, there's inequity in our roles, there's sexual harassment, there's pay disparities, and there's leadership inequity, breaking that glass ceiling that still persists. We know in US medical schools that there is, more women than men applying to medical school, but graduation actually isn't true. It's still more men graduating than women. It's never reached 50%. And there's a lot of reasons that women leave medicine, even through medical school, and then when we move beyond medical school. We know that when we look at women departing medicine, especially in academics, this is from the AAMC data, and you can see the green line represents departures, and then the purple lines are new hires. And we know that, there's more people being hired than departing academic medicine, but there's still a fair number of people departing. And where do they go? Sometimes to private practice, sometimes to different academic medical centers, but sometimes they leave medicine altogether. And that is a shame. We train people because we need our next generation of physicians. And for women specifically, these numbers are much higher than we see in men. We know also there's a trickle-down effect. So we have lots of applicants, lots of graduates that are women, and residents and faculty as well. But once you start going down to the leadership roles, we start seeing less and less. And we could say even the same for underrepresented minorities. In fact, those numbers are even worse. And we talk about this leaky pipeline. I've heard about this leaky pipeline since, I was in medical school. Well, either plug the holes or change the system. Let's stop talking about the leaky pipeline and fix it. This is, something we need to change. I'll show you also that, cardiology specifically, we know that it's hard to get women or minorities into cardiology. And we've been struggling with this. We've been meeting about this, trying to figure this out. You can see surgery here in the orange bars, and the lighter blue bars is men. You can see surgery has really done a great job of getting women into their field. Whereas cardiology, it's going to take us many, 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 many more years, probably more than 50 years to get 50% women into cardiology if we keep continuing at the rate we are at. Right now in cardiology, less than 6% of cardiologists self-identify as an underrepresented minority. And as I told you, 14% women. And when we look at, the race, more of them are Hispanic versus Black versus Indigenous in terms of our underrepresented minority. So we know there's this problem exists. And in 2016, there was a survey done of training program directors in cardiology. They had quite a good response for a survey, and almost everybody, 84%, said underrepresented minorities were truly underrepresented in their programs. What they found, though, is they asked them, what are they doing to change things, and how do they choose their fellows? Well, 63% of the program directors said, our program is diverse already, so diversity doesn't need to be increased, and yet our numbers don't match up with that in any way, shape, or form. And when they were asked what are the things that they weigh to get their fellows, clinical skills, good one. I think that's important. Ability to fit in, team player. Well, then that's often going to mean that you're a man or you look like us. And the very little weight for cultural competency, diversity, even humanitarian compassion. You'd think that would be like something we really want to care about, 10%. Other ones seem reasonable, but I think the ability to fit in is the way that program directors are weighing who should come to their fellowship program. And in fact, 37% of program directors said that they were interested in increasing diversity in their program, but only half of them had a plan to achieve this goal. 69% believed the following statement was true: diversity is a driver of excellence in healthcare delivery. But of those who chose that, only a quarter could give us supporting references to support that statement. So what the researchers decided is that a sizable minority were actually uncertain about the benefits of diversity. The majority were unfamiliar with our published literature citing the benefits of diversity, and most didn't prioritize this when they were recruiting fellows in training. So how are we going to get diversity in our next generation if our program directors really don't recognize this? Well, what's the benefit of having diversity? And women is part of it, but I would also say underrepresented groups need to be included in that. So we know that women and underrepresented minorities are more likely to follow our cardiology clinical guidelines, and they're also more likely to provide care for underserved populations. Seems like a good reason to have more diversity in medicine and in cardiology. Women physicians have been shown to have more likely to have patient-centered communication and provide health counseling compared with male physicians. There's lots of data. I gave you lots of references below of studies that have looked that when women are practicing, the patients are more likely to do better. Acute myocardial infarction is shown over here. Men are shown in the red line and women in the blue, and that female physicians took equally good care of men and women with an acute myocardial infarction with better survival of women in contrast with men. So, but heart failure, we have data like that as well. Diabetes, we have better outcomes with female practitioners, reduced mortality and readmission in the treatment of myocardial ischemia. And we know underrepresented minority patients want to be seen by patients that look like them. So it's what our patients want. We should be also then answering that. I hate labeling them as the consumer, but we serve them. We look in cardiology at other ways, our leadership and our diversity in leadership. And one way for us to look at this in a paper that we published this year was really looking at our societies. And you can see that in all the years since we've had societies, we measured the percent of female presidents to male presidents in our major national societies. And it's really, if you call it president years, we've had 90% president years and only 10% women years. And again, predominantly white, and very little representation of people of diverse backgrounds. And again, we understand that there was very few women early on in cardiology and in medicine in general, but we just wanted to show these time trends of women compared to men. And we also provided some solutions so that we can change this. We are doing better in cardiology. You can see more diversity, more women, more people of diverse backgrounds being in our national societies. But we know it's not the society so much as our hospitals and our universities putting our diverse background up on the stage, putting people who don't look like them as the leaders. That is the way that we will change them, allowing them to run trials, allowing them the leadership roles. That's how you become the head of your national societies, is really by being front and center at your own center. And we look at guidelines too. There's great inequities of women in guidelines. And that is a paper that we also published this year looking at over time. Certainly the US is doing better than the Canadian or the ESC. We looked at all of them to look over time trends, and we are making changes, and these are good. But we also saw some of the barriers, that it was less likely to be an MD, more likely to include a PhD in guidelines. But when a woman led guidelines, there was more likely to have more women on the guidelines if they were the chair. And so there's things that we can do to improve the equity, to promote and nominate women in cardiology. And this applies to medicine in general, because we always know when there's leadership roles, they're more likely to look at men than women. Now, when we look at trials, we know women are likely to be included in trials, less likely to be the PI, more in NIH studies, but industry less likely in device trials versus drug trials. But this is specifically for NIH trials as well as industry funded trials, because this is what this study looked at. And this study was actually done by some people at Stanford. I don't know if Dr. Young is still with you, but I know she led this. So they looked at this and they showed that, again, there was a paucity of female PIs, but when there was a female investigator, they were more likely to recruit women into their trials. So there is a value to having women as PIs. And when another paper looked at this in terms of trials that are published, again, most of the studies did not have female at all in their leadership committee. And more than 40% of them did not have female investigators when they were published in, our leading medical journals. We know that we need more diversity in our trials, and there's that this is our patient population, and that means getting more diversity in women into medicine. We know that this is our role, is we will never understand the diseases that affect the people the most if they're not also included in our studies. So we know they're underrepresented, they're underreported. It limits the potential of our research. And we spend so much money on research, and then we're not actually closing the gaps, because we often say this might only apply to white men, or this might only apply to X population. So again, that's why it leads to mistrust and fear, and patients don't really want to come and be seen by doctors. So we really need to diversify our team. And this is true for our research team, but this is true also for our healthcare team. If we increase diversity, we will get more diverse populations enrolled to our study. We will have increased generalizability of our findings. We will have an increased profile of those researchers from different backgrounds, and that will be an inspiration for more research to pursue clinical research. And again, this will be a continued cycle. And I think this is the reason that we need to have everyone everywhere. So, we know that we need diversity for our patient population and for our research. We know that we need more equity in medicine, both in leadership, but also in pay. And these are issues we deal with. We know there's bias. I've shown you many many examples of bias in cardiovascular care, but I'm sure many of you can show me bias in other parts of medicine. We know what affects women in cardiology, but also in medicine, is sexual harassment, often in the form of gender harassment. We need to have zero tolerance for that if we want to keep women in medicine. And we should incorporate metrics for our leaders to achieve retention of women, advancement of women, advancement of people from underrepresented backgrounds. That should be how they are also measured as being a good leader. And these are ways that we can improve the environment for everyone to get more women and more people of diverse backgrounds into medicine, and also ultimately improve the care of our patient population. So just in general, let's get rid of the mantle. I know Dr. Harrington took a vow to not be on mantles, and he is a huge leader for us within the cardiology community. And I think that that is one solution. MAPers or papers that don't include any women, we should really be uncomfortable with that and think about that. And mentoring, it's a man who only mentors other men. Don't be a mentor, seek out women to mentor, do it again, and no mustaching, meaning only filling senior leadership roles with men. These are things that we can do and start changing our community for the better. Because yes, I am here too, and so is she, and so is she, and so is people from other backgrounds who may or may, depending on their where they're from. So I think, men need to be our allies. We have many allies in our community, and I think that is what's going to change this. This is a quote from Dr. Carlos Del Rio, the dean at Emory University, and he talks about the need for women in medicine and how are we going to change it. And he said, shattering this glass ceiling is an urgent priority, and we cannot expect women to do it by themselves. As men, we need to work side by side with women colleagues, pushing for gender equity. This is not only the right thing to do, it is the smart thing to do. So I hope I've convinced you that these things intersect, that women remain understudied, underdiagnosed, undertreated in cardiovascular disease, and they're underrepresented in cardiovascular trials. We need women to be studied. And the way women will get studied is to have more diversity in our trials, more diversity in our leadership, more diversity in medicine. We can improve the cardiovascular care for all of our patients by working within our medical system to improve the equity, the diversity, the inclusion, and justice in medicine. So again, sorry if I took up way too much time, and I hope I've left some time for questions. Again, thank you for having me here.
Thank you so much, Dr. Gulati. That was amazing. You covered so much ground and so much data, both on the patient outcome side and on what's happening with the workforce. There are a couple of questions in chat. If for folks in the audience, please feel free to continue popping them in. We do have a few minutes here for discussion. The first one I want to ask comes from the Q&A. It says, enormous resources have been devoted to heart-related studies conducted exclusively in women. And you'll know these acronyms, but I don't know all of them. PEPI, Women's Heart Initiative, and SWAN, for example. The problem, this person says, is that the focus has been narrow, the events surrounding menopause and its management. Do you think perhaps the blame for the situation that you describe is a tyranny of cardiovascular epidemiologists and study sections favoring revisiting the same old questions rather than funding studies of diagnosis and therapy in women?
Well, I mean, I would say Women's Health Initiative is the greatest example of those. WHI, it was the study that Dr. Bernadine Healy, when she was at the NIH, fought for, and it was needed. And it was an important study. And was it perfect? No. Is it ever going? But did it answer some questions for us? Yes. And will we ever get funding like that again in our lifetime? I don't think so. I think that we need to continue asking the questions and not necessarily revisiting always the same things, but there is times that, we have new therapies. We have to revisit studies that we thought we had the answer to. I think I had somebody in medical school tell me that when you think you have the answer, it's time to go back and look again and see if they really do. Things change over time, and maybe the way we said yes for one thing might have changed over time. But I think I would not blame the epidemiologists. I wouldn't really blame anyone. I think things change. We need, though, more research. And I think there are studies exclusively of women maybe at that time were important. I think as moving forward, we should be looking at sex differences and really including men and women in trials so that we have comparisons, but holding our studies accountable. That has been the hardest part. There are studies, I was just at the European Society of Cardiology. We saw one study there, no women whatsoever. Another study, 17% women. You'll often see me tweet this stuff because it's the first thing I look at. I'm like, where are the women? Can I apply that to my patients? And we could say the same for people from diverse backgrounds. Sometimes you're like, well, who does this represent? People that are Black, people that are brown? We're often excluded from those trials. So I think we need to be more pragmatic about our trials, meaning let's figure out ways. WHI was a huge initiative. It would be hard for us to replicate, but we have new ways of doing things. Data, electronic health records, ways to share information with one medical center and many medical centers. So let's be pragmatic. Let's harness our electronic health records. Let's use artificial intelligence. Let's use national databases. Let's work together to get answers for common questions. And let's be inclusive. And let's start holding our funders of research, both industry, government, and anything else, accountable. Why are they not holding investigators accountable when they have to say, yes, I'm going to include women in the study. Yes, I'm going to represent diverse populations. And then when they publish, we see they didn't. Don't give them the money for the research if they're not going to be accountable.
Yeah, I love that point about accountability. A quick related question on this idea of who's being enrolled into trials. What are your thoughts on responsible ways to present research from clinical trials to acknowledge who exactly is represented? What should folks be doing when we're presenting data, regardless of what specialty, when we're presenting clinical trials data with regard to that?
Well, I think that, population prevalence of disease is one way that we should be designing our studies. If a disease disproportionately affects a certain population, so you're studying diabetes, Hispanic population definitely should be represented in a bigger way than maybe if you look at our population just in general. So we have to be more strategic, because if we talk about heart disease, for example, killing more Blacks in America than any other group, and yet we underrepresent them in almost every single trial we do. We can't do research the old way. We've got to start shaking it up. And again, that is also why we should be pragmatic about our research. We should be thinking about ways to enroll the people that are living with the disease, because that way we're getting the people that, helping the next generation, hopefully, by seeing this. We've known so much of our epidemiology for years. So now we got to change that.
Yeah, absolutely. Okay, one last question in our last 2 minutes, coming again from the Q&A online. This person asks about tech and diagnosing women with ischemic heart disease. Do we have better imaging, for example, to see the small vessel disease? Are we changing the metrics for defining STEMI in men versus women? What's the latest there?
Yeah, so those are great questions. So, one thing that has changed is how we diagnose myocardial infarction. For just as an example, most places are using high sensitivity troponins, and high sensitivity troponins have been shown to have sex specific thresholds. So meaning there's a different cutoff for women versus men, more sensitive specifically for women for diagnosing myocardial infarction. That is one such sex example that has changed over time. But our other technologies, yes, for small vessel disease, ANOCA and MANOCA, we have great technologies now. We have in the chest pain guidelines, you can dive into it a little bit more. I did share those guidelines, and we talk about evaluation for that. And of course, it applies more to women, but we have data now of using in the cath lab doing diagnostic testing, as well as using cardiac MR and PET scanning that is much more sensitive technology to really diagnose myocardial ischemia in a better way. We need more artificial intelligence, as well, as I mentioned, to be incorporated into our usual care. And I think we're seeing emergences of this where we're at least having studies. So I think that is our future.
Yeah, that makes a lot of sense. And thank you for sharing those insights. We are at the top of the hour, and I want to be respectful of everyone's time. Dr. Gulati, thank you so much for joining us today and enlightening us, teaching us so much about women in cardiology, both as patients and as physicians and other healthcare workers. Everybody have a lovely day, and we look forward to seeing you next week as we continue our celebration of Women in Medicine Month and add to that celebration of Hispanic Heritage Month. Everybody have a great day.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.